We also have a first. We're going to be streaming and recording this presentation so that others can access it and expand our visibility and reach. But our final speaker is Dr. Paul Lyons. Paul is the Chair of Family Medicine and Senior Associate Dean of Education at the UC Riverside School of Medicine. His medical degree is from Ohio State University, and he was previously associated with Temple University. Those of you who know anything about the UCR Medical School know that it is relatively new, and I recall that when it was sort of in its planning phases and so forth, everywhere I looked, there was Paul Lyons' name. He was the very first clinician hired by the UCR Medical School, and he has been essential to getting this enterprise off the ground and maintaining it. And it's a pretty significant resource, I think, for the Inland Empire region. So Paul's talk today is called Assessing and Addressing Healthcare Needs of Inland Southern California, with a little shout out to the Brits, Mind the Gap. So I've asked Paul to speak for about 40 to 45 minutes, after which we will have a discussion period that I expect will take us maybe 1:15, 1:30, somewhere in that area. In any case, I hope that you will welcome Paul.
So thank you, it's lovely to be here. A couple of caveats. I'm usually a wanderer, and I've been told I'm not allowed to wander because they're filming. So if I seem more stilted than usual, it's because I'm leashed. And to the people in the front who are filming, when I fail and I wander anyway, just clear your throat and I'll come back and I'll hit my mark again. I promise I'll do my best not to wander. As mentioned, I'm the Senior Associate Dean for Education at the School of Medicine, and I'm the Chair of Family Medicine. I'm going to bring those perspectives to what I'm talking about today. Assessing and addressing the healthcare needs of Inland Southern California is what I was told to talk about today, and I am very happy to do so. As you might imagine, that's an extraordinarily broad topic, which I couldn't possibly address in all of its complexity before we need to break at the end of this session. So I'll talk in a minute about what the lens is that I'm going to bring to that, which is a little bit narrower than the title might suggest. I've promised to be sensitive to time, which means that I will work my way through my slides in a way that sort of fits into the allotted space. However, I'm always happy to take questions from the floor, so if I've said something that sounds crazy to you and you would like to actually address it in the moment, I am happy to take that question from the floor as well. So I chose Mind the Gap because it has, I think, three significances that I think, is that correct? That sounds terrible, but three significances, we'll go with that anyway. One, mind the gap in the way that it's usually used, which is there's a gap there, be sure that you notice that it's there and step over it so that the train doesn't run you over. And so we'll talk a little bit about what the healthcare needs are in the region. Mind as in, do you mind, or I mind that this exists, so sort of defining the extent and the significance of the gap as it exists in Inland Southern California, hopefully give you a sense that we should all care that this gap exists. We should mind that this gap exists in Inland Southern California in a way that is more significant than it is both nationwide and also in most areas of California. And then mind as in, like, would you mind your little sister while we go shopping? What would we do about this? How would we care for this gap? Having identified that having noticed that it exists, having developed a sense of urgency about the need to do something for it, what would we do to sort of help take care of that gap? And so those are the three kind of senses that we were, destinations, if you will, on my metaphorical train this afternoon. It is, as I mentioned, a very complex question or issue, and I will not touch on all of it. So let me tell you what the lens is that I'm going to bring to this. I'm going to talk about this in terms of health workforce development issues and how we would develop a health workforce, and specifically an MD physician workforce that is suited to help address the healthcare needs of Inland Southern California. I believe that there's a fairly significant ethical component to the way that we structure medical education, which sort of requires us to be aware of what the healthcare needs are in the region in order to align workforce preparation, physician training, if you will, to allow them to actually be effective in working to help decrease sort of healthcare gaps in whatever region they choose to practice. And the failure to do so, which is long-standing in medical education in my assessment, is actually, again, from my perspective, an ethical lapse on the part of medical education, that we have not actually aligned our educational models with the actual needs of the health workforce in medicine. So that's the lens that I'm bringing to this. For those of you who think that sounds exquisitely boring, I promise not to pay any attention as you go find lunch early. But that's what we're going to talk about for the next 30 to 35 minutes, if you will indulge me. So let's talk a little bit about sort of mind the gap number one. What are the issues that we would want to be aware of in inland Southern California? Now, I understand, and I'm sure that you actually understand as well, that there are issues that span the entire United States. We have healthcare needs of an extraordinary scope and nature in the United States. We spend twice as much as our nearest competitor and get about a quarter of the value. I'm sure you've heard that at some point over the course of this semester. I'm not going to touch on that, although it is true and it is important. I want to actually focus on my neighbors and what are they facing in this region. In part because that's important to me, but also in part because that was the mission of the school that I came here to help found, which is the UCR School of Medicine. We actually identified the health needs of inland Southern California as being our reason for existence. And so that's what I'm going to focus on today. There are a million ways that I could sort of slice this pizza, but let's just talk about a few. Let's talk about the prevalence of physicians in this region. We have about half as many primary care physicians as we would need to provide basic level care for the residents of Riverside and San Bernardino County. That's an absolute shortage of about 3,500 to 4,000 primary care physicians missing from Riverside and San Bernardino County. To put that in perspective, we produce about 26,000 physicians, new physicians, each year across the entire U.S. medical education system. We need 1/5 of them in Riverside, San Bernardino County right now, in primary care, in order to meet the gap that exists today. Primary care is our most significant need, but if you need a neurologist, or a radiologist, or an anesthesiologist, or any ologist that you know how to name, or any of your elderly relatives know how to name, we're also missing them. Not quite at the same degree. We have about 64 per 100,000, and we need somewhere between 85 and let's say 100 per 100,000. So the gap is not quite as large, but the gap exists. The only specialty in Riverside and San Bernardino County where we have as many physicians as we theoretically need numerically is dermatology. But in every other specialty area, we are missing physicians. Without my glasses, I can't tell where I am. So worse than that, however, in addition to not having enough physicians, it turns out that they're all old and decrepit like me. Which means they're not good for very much longer. So 40% of our existing physician workforce in this region is 55 or older. In the Kaiser system, there's actually mandatory retirement at 65, which is not helping us. But there's actually a move nationwide, not a move, a trend nationwide, that physicians are actually leaving practice earlier than they historically have. So we're actually being generous to say that that 55-year-old physician has 10 more years of active practice life. But even if they did, that means in the next decade, we're going to lose approximately 40% of the physicians who exist right now, exacerbating the gap that exists in the workforce, which is already too big to step across. We also have the wrong kind of physicians. So not only are we old and decrepit, but we don't look like the population that we're serving. Only 6% of practicing physicians in this region are Latinx physicians. You guys, I'm sure, are aware that the population in this region is right now or will very soon be majority Latinx population, 49, 50%, depending on how you measure and when exactly you measure. That is who lives here, and that's not what our physician workforce looks like. Now, I picked that because that's the most predominant ethnic representation in this region, but you can pick any of the sort of rich ethnic diversity of this region, and we are missing physicians in those disciplines, from those ethnicities or from those backgrounds. not on this slide, but about 60% of all physicians come from the top economic quintile. So future physician medical students, they come from the rich families. Riverside and San Bernardino County, that's not our socioeconomic background either. So we're getting physicians who are not representative of the communities we are asking them to serve. Some specifics: if you want to have a baby, good luck finding an obstetrician. For those of you who are male and therefore crazy, good luck finding a psychiatrist. And again, the psychiatry workforce that we have represents the same lack of diversity that our workforce as a whole has. So what's kind of the outcome? Oh, actually, no, not yet, not the outcome. Let's look at what we're talking about in terms of the scope of the problem still. So we have a population in our region which is poorer than the statewide average, and actually poorer than the national average as well. So we have almost 50% of our population living at 200% of the poverty line or less. I'm sure over the course of this semester you have talked at some length about the intersection of wellness and economic well-being, and the challenges associated with being socioeconomically stressed and maintaining your health and wellness. We have a population that faces that. Almost half our population faces that on a daily basis. We have 17.2% of our population uninsured, meaning they don't have access to care, even if they can find a physician with an address and a door that's open. That's, again, about 50% higher than the national average. And meanwhile, the population in this region is only growing. So I know you're wondering why it is I picked these particular dates, so I will tell you. In 1988, when I stole my wife from Redlands, California and made her come back to Ohio with me, you had 1.2 million people in this region. In 2011, when she finally convinced me to come back and help start the medical school, you had almost doubled to 2.2 million people. By 2020, essentially where we sit right now, we've added almost another million people. We're at just shy of 3 million people. And by the time I keel over dead, at roughly 90, you will have 5 million people in Riverside and San Bernardino County. That is an extraordinary population growth in this region, all of whom have healthcare needs, and all of whom are demographically like this. So we have not enough physicians right now. We have an increasing population, and that population is at higher risk than the average state population or the average nationwide population in terms of healthcare ill outcomes. So again, there are a million ways I could show you this, but let's just talk about a few. Riverside and San Bernardino County have the unique distinction of fighting each other for being the worst in the state about almost any measure you would choose. So San Bernardino is 7th worst in breast cancer outcomes, and Riverside beats them in that category. They're only 12th worst. Diabetes has the 3rd worst outcomes related to diabetes care of any region in the state. San Bernardino actually doesn't do very well in terms of heart disease, nor does Riverside. We are bouncing along the bottom of the major disease killers, frankly, nationwide and within the state. A direct, not exclusively related to the physician workforce, but a direct consequence of this gap between the needs of the community that we're serving here and what's available to actually help us meet those needs. The outcome of which is that we are in the lowest quartile in any healthcare measure you would choose to look at. If Riverside County is not at the bottom, San Bernardino County is at the bottom. In any one you would choose to look at. So there's this interesting model, 3-4-50. Anybody know what that is? Anybody seen that before? It was developed actually in San Diego. Public Health Department in San Diego said there are 3 behaviors that create 4 basic medical conditions that are responsible for 50% of all deaths in our community. And we'll look at them in just a second. But those conditions actually are even more significant in communities that are socioeconomically distressed. So in in San Diego County where they developed this, they call it the 3-4-50 or 3-4-5 model. And it's cute because it's sort of symmetric, right? Well, Riverside and San Bernardino County, I don't have the number for San Bernardino County, but in Riverside it becomes the 3-4-63. 3 behavioral components drive 4 medical conditions that are responsible for almost 2/3 of all deaths in Riverside County. And I'll show you what that looks like in just a second. But those are behaviors that are more predominant and harder to address in communities that are economically stressed. And therefore, it's not surprising that in an economically stressed environment, the impact of those 3 behaviors is a higher prevalence of those 4 diseases, and therefore a larger percentage of deaths in our region come from basically those 3 behaviors. So, as you might imagine, what's killing us are chronic diseases. The age where we could identify a bug and develop an antibiotic and give it to somebody and they would feel better and that would fix mortality, or when there was a body part that was causing a problem and we would cut it out and everyone would live longer, those days are mostly gone. What kills us these days are chronic disease processes. I don't know if you've seen this before, but you may have. On your left, my right, are the classically reported leading causes of death, led by heart disease and cancer. And if you're a public health wonk, then the one on your right, my left, is the one you want to look at. These are essentially the real causes of death. I don't know if you can read that from the cheap seats in the back, but tobacco, #1 sort of cause of death. #2, poor diet and physical activity, which they put together, and you can work your way down the list here. Alcohol consumption, motor vehicles, firearms, sexual behavior, illicit drug abuse. The one that I skipped over is microbial agents, infection. But you'll notice that of the 10 actual causes of death in the United States, this is from 2000, but the same data applies in 2010 and will apply in 2020 when we repeat this study. Same data will apply. You'll notice on this side, what's missing? Anything medical whatsoever. Anything medical whatsoever. Only one thing that I actually learned about in medical school is on this list. I am completely and utterly befuddled by what it is I'm supposed to do with this list. And I don't think it's just because I'm an idiot. I think it is, in fact, a disconnect between what we are asking our physician workforce to address and what we're actually teaching them to do in their professional role. And that, I think, is the nub of the issue that hopefully I'll try to drive home today, and which we've been working on as part of developing the medical school at UCR, to help sort of bridge that gap, if you will, between what we actually need to be addressing and what we are currently teaching our physician workforce to effectively do. So here's the specifics of the 3-4-5 model, if you will. 3 behaviors, which actually on the last slide were actually incorporated as just 2 on that graph. Poor nutrition, lack of physical activity, and smoking. Those 3 things alone drive 4 medical conditions: cardiovascular disease, which is essentially a heart attack and stroke, diabetes, cancer, and pulmonary disease, which is fundamentally one thing, COPD. So chronic bronchitis and emphysema. Those 4 diseases, which in Riverside County are responsible for 2/3 of all deaths. In other words, if we could effectively work up here, well, frankly, you 2 would still be alive, along with me. We would bend the curve in truly meaningful ways if we could impact mortality rates for 2/3 of the population. Now, just to be clear, so I'm not a statistician, but I do understand that the mortality rate of a living human being is 100%. So I get it. All of these people were going to die from something eventually. I have lost all of my patients who have died. And I will lose all of my patients to death eventually. I get that. That's not what I'm arguing. But what I am arguing is that the actual cause of death and the timing of that event are actually driven by a finite number of specifically identifiable issues. So, let's do something about this then. I've made the case up till now that in a whole variety of ways, our region, as a microcosm for the nation as a whole, has some significant gaps between what the healthcare outcomes could be and what they actually are. And I haven't yet made the case, but I'm going to make the case, that the gap that we need to actually cross is the gap between what we are teaching our workforce, healthcare workforce to do, and what, as you saw, they actually ought to be able to do. So part of it is that in medicine, we hate change. So, this is the Columbus Roadster. It was all the rage in 1910. It was cutting edge. From the Columbus Buggy Company, which was the Microsoft of its day. It saw that buggies were dying and cars were all the rage. And in 1910, they put out that fancy piece of technology right there. And in exactly that same year, Abraham Flexner described the U.S. medical education system in what was called the Flexner Report, identifying both gaps in the education as well as what he thought should be the ideal model for education. Now that's fine. I'm all for surveying what the gaps are and how you might do it differently. That model described the medical education system as you would see it today. 110 years later, we are operating as if the Columbus Buggy Company were still cutting-edge technology. In 1928, the Yankees swept the Cardinals in 4 games straight, and Babe Ruth outperformed the entire Cardinals starting lineup. And in 1928, we introduced what would become the MCAT. So any pre-med students? Anybody silly enough to be pre-med? So you know what I'm talking about, MCAT, right? Like the bane of admission to medical school, the MCAT. Well, it was introduced in 1928 and has not meaningfully changed since that time. The questions are a little different, but they're actually not meaningfully different. Somebody, Babe Ruth, who never took the MCAT as far as I know, could come back and would both recognize baseball as we play it today and the MCAT that was available in his day. We have not meaningfully changed the way we let people into the workforce in at least medicine, nor the way we train them once they are in the pipeline, if you will, in over 100 years. And you can't really be surprised if you keep doing things the same way that the outcomes would look very similar to what they have always looked like. Meanwhile, the world as we know it doesn't look anything like 1910. For a little while there, just about the time I came here, it looked a little like 1928, or at least 1929, but it really is not the same world. But you wouldn't know that looking at the House of Medicine. So, I believe that medicine and medical education is really almost nearly perfect, except for the wrong people in the wrong place, doing the wrong things in the wrong way for the wrong reason. And other than that, it's flawless. And I won't have time to talk about all of these elements, but let's step through at least a little bit of what I think that looks like. So, let's start with the wrong people. And not really the wrong people, like I've been in medicine my whole adult life, right? I have 1 or 2 people in medicine who I actually like, so I'm not, and I am a doctor myself, I don't have a particularly well-developed sense of self-loathing. So I'm okay with the people, but it's not reflective necessarily of the broad richness of humanity that I think could contribute meaningfully to the practice of medicine. So let me give you just sort of one snippet of how narrow this pipeline is. So I'll give you the numbers, 119 and 2,500 In the United States, there are 2,500 four-year degree-granting institutions, colleges and universities, 2,500. In the state of California, we have almost 120. So inside our own borders, about 120 institutions, just like this one, granting four-year degrees. So you might imagine that the pipeline into medicine would be spread over a quite wide range of educational experiences and opportunities. 20% of all 52,000 applicants last year came from only 20 schools nationwide. 1 out of every 5 came from only 20 universities or colleges in the entire United States. But wait, you know, because I have the fancy PowerPoint thing going on that something else is coming. 1 in 8 come from only 10 schools. 10 universities nationwide produce 12.5% of all U.S. med school applicants. You knew I was going to criticize California, didn't you? 1 in 15 nationwide, I'm not talking in California, 1 in 15 applicants nationwide comes from somewhere in the UC system. Now, I'm in the UC system, I'm quite proud of what we do, but we are not 1/15 of higher education in the US as a whole. 2% of all applicants came from UCLA alone. Now maybe it's just my bias for the snobs at UCLA, but they don't deserve 2% of the business in medical student education. Who's not in the mix? Lots of examples, but in our own state. In my assessment, richest, most diverse undergraduate environment statewide is the Cal State system. And it's quite large. It's the largest public university system in the nation. And not a single campus made the list of schools producing at least 50 applicants. I'm not talking about 50 people getting in. I'm just talking about 50 people who felt like they were worthy to ask to get in. Not a single one of our Cal State University partners made that list in 2018. We are not bringing in a population to medical education that is reflective of who we are as a nation. And consequently, we can't really be surprised that what we put out the other end will likewise not be reflective of who we are as a nation. Now, there's lots of reasons to care about that, but that, to my mind, is an ethical challenge in the way that we approach workforce development in healthcare education. So, wrong people in the wrong place doing the wrong things for the wrong reasons. This is a study from about 2001, which repeated the study from 1961. In a couple of years, it'll be repeated again, and it'll look exactly the same. It's a little busy, so I won't make you read the whole thing. But this basically says, if I took 1,000 people in any given month and just assess what happened to them from a kind of a healthcare needs perspective, 1,000 people, about 800 of them would at some point over the course of that month say, I don't feel well. And of those 800, about 300 would say, I feel not well enough that maybe I should go see somebody about that. And of those 327, 217 would actually go see a doctor. So we're already saying by the time you see the physician, you're a minority of not only the 1,000, but you're actually a minority of the people who didn't feel well over the course of that month. And I won't walk you through all of these various options, but this little tiny little thing down there that none of you can read, even the people in the fancy seats up front. Even the people who could do this with their fingers and expand how magnified they are can't read that. And what that says is that less than 1 patient out of those 1,000 ends up in an academic medical center. In other words, healthcare never exists in an academic health center. Now, where do you suppose we train all future physicians? Well, down here in this little tiny corner, where frankly, nothing is going on. And there are very real life consequences of that decision. I won't go into all of them, but let me just give you what I think is a relatively concrete example. If you train with a neuro-oncologist, someone who does brain cancer, the kind of person who would be quite happy in an academic health center, right? What does every patient with a headache have? They've all got cancer. Your perspective, the lens we have now given you, is that headache equals cancer. Why? Because every patient you saw with a headache had cancer. Why? Because you were working with the headache is cancer doctor. But you all know from your personal experience that a headache doesn't actually mean you have cancer. It means you need Tylenol. And maybe a little more sleep. And maybe a little less stress about the fact that you're almost at the end of the semester. Or a little less stress that pretty soon only about 9 of us will be in the room and I'll be a lot closer to you than I am right now. That's what causes headaches. But we don't train people to think that way. We develop a series of filters and worldviews that require them to think in very different ways. Those have very real life economic and healthcare consequences, right? If you come to me and you've got a headache and I'm convinced that means you have cancer, we're going to immediately order a $3,000 MRI, not a $3 bottle of Tylenol. That's a very real consequence from an economic perspective. If you continue to complain about your headache, I'm going to do something invasive like stick a needle into your spine, because if it's not oncology, then you've got some terrible infection, which I also learned in the academic health center. Now, not only do we have cost, but we have risk. And I'll be the first to admit that there's those patient safety caps, they're kind of hard to get off, so there's a little risk associated with that. I've torn skin from time to time and certainly broken nails. But it's not the same risk of my taking a large, sharp, pointy needle and shoving it into your spine, accessing the fluid that surrounds your brain right now, and essentially opening a track from your brain to the outside world. Now, obviously, I've made that sound a whole lot worse than I do when I consent patients for that process. But it's not hard to see that that's actually got very real health and wellness consequences for the patient. So there are economic consequences, there are health and wellness consequences, and all of that completely misses the point that you didn't need it in the first place. Wrong people in the wrong place, doing the wrong things in the wrong way for the wrong reasons. So what would we do about this? Because I don't think we have to sit here unchanged and unchanging for all of forever. So there are a lot of things that we could do differently, and I will not have time to touch on all the things. But the first thing is to put the ladder where it matters, and you got to read the quote to understand what that actually means. But Stephen Covey says that essentially efficiency is how fast you get up a ladder, and leadership is actually where you put the ladder. In other words, you can go be really efficient at doing the wrong thing, and that doesn't really help anybody. And in medical education, we are really efficient, but our ladder is in the wrong place many days of the week. So let's talk about a few things that I think would put the ladder in the right place. So the first thing, as you saw, is that most healthcare need exists outside the academic health center. And as we said way back, that sort of chronicity keeps happening. The actual delivery of care works this way across time, not this way across episodes, right? If you really want to impact people, you need to be in a setting where you are with them for the full ride on the train. You're not just at the Claremont station. And so medical education would be better served if right from the very beginning the primary clinical experience was both ambulatory and longitudinal, designed to send the learner back week after week, year after year. And so we built what we call the longitudinal ambulatory care experience, where our learners are paired with the practicing physician in a specific practice site. And they do go every single week for 3 years of the 4 years that we have them. Now, there's lots of reasons why, of course, I'm patting myself on the back about this, but I think fundamentally it's not about the fact that it makes me feel good. I think that is actually where healthcare happens, to the extent that people have access to the system at all. Now, it doesn't touch the 500 or so people who didn't decide to go see a doctor, but at least the 300 who did are in a doctor's office, which is where our students are now learning what healthcare looks like from that as the primary perspective, the primary set of filters or lenses through which they will interpret their future understanding of the delivery and practice of medical care. That might be one place to put a ladder so that it matters. Second thing is, I've already told you, we got the wrong people coming in. Now, we can fix that problem in the long run, and I'll show you that we've done a little bit of that. But in the meantime, to pretend that nothing could or needs to be done to help increase competency among physicians who are discordant with the populations that we are asking them to serve is just nihilistic madness. So the second thing that you might, a second ladder you could put up, so to speak, that would matter, would be to take that seriously. And so we developed, again, a 4-year longitudinal program that is designed to develop linguistic and cultural competency around, in this case, the communities we're most likely to serve, Spanish-speaking communities. Taking non-native, non-Latinx students who choose to engage in this curriculum and making them linguistically competent. They will achieve a level of linguistic fluency sufficient to pass, in our world, a required medical translation certification. But also the educational experiences we build for those now linguistically fluent students are in communities that they otherwise couldn't access because they don't have the linguistic skills to do so. So we put them, for instance, in the eastern Coachella Valley. In communities where Spanish is not only predominant, it's almost exclusive. Where they now are in an immersive, not immersive, not we're dunking them in there, but they can actually draw experience, immersive, what emerges in their education from being able to be in those communities. Producing, I believe, a cohort of physicians who, even if they don't come from those backgrounds, are now more effectively prepared to operate in those communities. The third thing is, how many of you have gone to see a doctor? Right? So how many of you, when you went to see a doctor, said, the doctor said to you, well, yeah, that's good. I'm not the doctor you need to see, but I do know the doctor that you need to see. How many of you have had that experience, or someone you know has had that experience? Yeah, that's a fair number of you, right? In medicine, we love this. We are not lumpers. We are slicers. We like increasing sophistication around increasingly irrelevant specificity. That's what we love. That's what we all love. But it's not from the patient side of things, actually, the experience. You don't go to the patient, to your doctor and say, I'm having crushing mid-sternal chest pain. I'm pretty sure that's a 90% occlusion of my right circumflex artery. Right? You say, my chest hurts. And that could be your heart, or it could be your lungs, or it could be your GI tract, could be musculoskeletal. Maybe you're about to get a rash and it's actually shingles, God forbid. Who knows? You don't know. But we actually ask you to know that so you know which doctor you're supposed to go to. We believe, and we have built, the educational system that we put together in most medical schools is you're a surgeon for 6 weeks, and you learn everything about surgery there is to know, and then we test you, and then you can purge that. You'll never need to know it again unless you become a surgeon, and then you'll be a pediatrician for 6 weeks. Then you'll know everything about that. Which doesn't actually teach you anything about what the real lived medical experience is, which is all at the intersections. Where do these things go together? How would you need to know, and how would you parse what patients are going to bring to you in order to help them to understand what they actually need from the system. So we built, and again, I think there's many reasons why you would want to do this, but the intersectionality of what I think the future physician workforce needs to know, an integrated clinical experience where they are actually a surgeon for a little bit while simultaneously also being an adult internist. They're an obstetrician while simultaneously being a pediatrician. They don't get to slice until they understand what the lump actually looks like. That's where they learn. And again, it sets up a series of filters or kind of worldviews, if you will, that said you start with a global picture and work toward greater specificity as it is appropriate. Not specificity is a goal in and of itself because that's how I define myself as a practicing physician. And finally, medicine is a team sport, and doctors are terrible teammates. We are the Babe Ruth of the healthcare system. We think we are all that and no one wants to be around us. And there are times when that's great and we will dominate the Cardinals, but there are other times when the other 8 players actually need to contribute in order for the team as a whole to get the job done. And so medical education historically and health professions education historically has done a terrible, terrible job of looking for opportunities to build educational structures that actually force people to work together in shared learning experiences. So we built what we call the Southern California Health Education Alliance, SoCalHeal. It's nothing if it doesn't have a cute name. Which brings together a whole series of health professions, nursing and pharmacy and PA and EMTs and physicians. And we built it in a way that no one owns it. It's very socialist, very shared among everyone, so that no one profession gets to say this is the way it will be as an educational, curricular, evaluative component. We will all agree. And if you don't like that model, well then go find a different partner, because the Southern California Health Education Alliance is built around the idea that we all sit at the table together and we build shared interprofessional educational experiences. I think there are some very real, tangible, in the moment educational benefits of that kind of experience, but it also, from the very start of the physician workforce pipeline, highlights the fact that they can't get the job done themselves and that they need to be able to work well in teams with other healthcare professionals. Another ladder placed where I believe it actually matters. And I won't spend a lot of time talking about this, but as I said at some point, I believe medicine is fundamentally not a science, but a social science based on science, and the contribution of the humanities to the breadth of the medical education experience, I think, is essential for what physicians actually need to do in the 21st century. So can you actually do this? You asked before, how have we actually done? Can you actually do this? Or is it just a pipe dream? Well, yes, actually you can. If you're committed to this as a vision and as a model, you can actually get this done. So right now we have 250 medical students in our medical school, and we will grow, but that's where we are right now. We've graduated 32 PhD students from a parallel program that has many of the same sort of philosophical underpinnings, but with a different educational outcome. And I don't know how much you know about medical education, but it turns out that when you finish medical school and you have your MD degree, you are fully qualified to work at Starbucks, and not much more. There's actually an additional step, residency training, which is actually required to become a full-fledged, competent, functioning physician. And it turns out that the 2 factors that predict where you will practice as a physician are where you grew up and where you finish your training. Not medical school, but the residency piece. And so, again, a whole talk in its own right, but we built these residencies from scratch so that we could start the train and stop the train in our region. I'll show you in a second that we draw our students from this region. So we picked up on that piece. But we also needed to build the other end so that they would end their training in our region as well. And we have successfully done that. So this is what our class looks like. This is the composite now across 7 total classes. 47% male, 53% female, slightly higher than the national average. I will say that males are dropping fast. It turns out it really is true. We're not as smart as we thought we were. And in even a semi-fair playing field, we get our hat handed to us with some regularity. But 47% male, 53% female. 70% of our students have a meaningful tie to inland Southern California, Riverside, San Bernardino, or Imperial County. They grew up here, they went to high school here, or they have significant family ties to this region. 34% are underrepresented in medicine. To put that in context, the national average is about 8%. This is higher than any medical college that's not associated with a historically black college or university. Highest in the nation. 45% of our students come from economically or educationally disadvantaged backgrounds. 32% are the first in their family to have completed college. And 18% of our first 7 classes, English is not their first language. It is possible to bring in students, people who look different than we have historically done. And it is possible then to put them in a new place, to teach them to do new things, to do them in new ways, 2 different proposed outcomes, and actually build something that doesn't look like the Columbus Roadster and pretend that that's all we will ever need. So with that, I think that's my last slide. Questions, thoughts, comments, concerns, uprising? Yes.
So when you created, all these, really interesting innovations in training, did you have to adjust or get an exemption from the accreditation standards that, I've forgotten the organization, ACE?
The LCME.
Oh, okay. So did you have to get, or were you able to work within those standards?
So you actually have to work within those standards. There's no such thing as an exemption to those standards. So you have to. And I will not say that it's easy, but I will say that it's possible. And because it's possible, the long-standing conversation, almost a half a century, where people said we couldn't do it any different way because the accreditation standards require us to do it this way, was largely an unexamined and false statement. Not easy, but not actually impossible if you took seriously the idea that there would be a different way to do it. Yes?
In the slide that you stated, we're not a very collaborative group of people, and I want to discuss that along with the new population, shall we say, of the students that you have
Yes.
at your school. Within the last 5 years, I was under the care of a team of physicians.
Yes.
I will say all of whom were female, and the team was incredible. They worked together all the time. Everybody
Yes.
knew what was going on at all times. So I'm wondering, in this new population that you have of your students, if you envision or if you work together in collaborative manners that will instill in them a sense of collaboration as they go out into the field.
Yeah, that's a great question. Thank you, because I didn't put it on the slide. But we actually build team-based function into our curriculum from the start, both in the classroom, where virtually all of our curriculum is delivered in sort of a small group, team-based problem-solving model, to actual simulation of clinical experiences where they actually have to function as a team. So we have those high-tech mannequins where they'll cry for you, they'll vomit on you, they'll talk to you, their pulse will go up, their pulse will go down, and we can build scenarios where the life of that mannequin is dependent on them coming together as a team and functioning. And we do that from the very first year of medical school. And then we've also built that into the next phase, which is residency training, so that for the students who stay with us, which is about 25% of our graduates actually stay in our own residency programs. There's actually sort of a 7 to 10 to 12 year arc of that shared culture of working together as a team. Now, we're not as unique in that. That's increasingly being driven by the economics on the other side, which says that if we need a team to make this done and we don't have good teams, that's an economic disaster, right? So lots of hospitals get that. But we are, I think, somewhat unique in suggesting, or in our approach, which is to prepare our students from day one for the idea that this is actually not a transition. This is what your whole life will look like. So it's not like you need to reach a certain point and then teamwork will be important. It is teamwork is how you get every basic function done. And that, I think, is a little bit different than some schools. Certainly different than the educational experience I had a million years ago. Yes?
You talked a lot about how you change the training once you have that diverse group, but how did you change the recruiting to get that diverse group? Have you reached out to some of the universities that have historically not gotten students to apply? Did you
Yes.
get a place like Cal Poly to get our students to apply?
Yeah, so we have a couple of things related to that. We have not done as comprehensive a job as we could or should do. But I'll tell you two things that we've done that have been absolutely instrumental. The first is that 24 of our seats are reserved exclusively for UCR students. And that's not because we love UCR or because somehow they pay our bills, because actually neither of those two statements is true on every day of the week. But it's an extraordinarily diverse undergrad campus. It's, depending on how you measure it in the year, it's the 4th, the 5th, the 6th most diverse undergraduate campus in the nation. And so to say that 24 or roughly 40% of every class that comes in is coming from one of the most diverse campuses in the nation, essentially, doesn't guarantee, but increases almost automatically the diversity. So we have not reached out to what I think would be the natural partner, which is the Cal State system, but we've done sort of a quasi version of that by linking explicitly seats to the undergraduate experience at UCR. So that's number one. And then number two is that in the state of California, Prop 209 says I cannot recruit around race or ethnicity. Right? I'm not legally prohibited from doing that. However, that doesn't mean that I can't recruit for other markers of what my community looks like. So my community, English as a second language is extraordinarily common. College education is extraordinarily uncommon in Riverside and San Bernardino County. So to give preference to first in family is by definition to get a population that looks more like my community than it otherwise would. And the four, if I can go back. This we just measure after the fact, but this we actually recruit for, and this we actually recruit for. And this we actually recruit for, and this we actually recruit for. Those are part of our admission metrics. If you meet one or more of those four criteria, and we talk about it explicitly at every stage of for every applicant, at every stage of the application and admission process, those four criteria. If you are explicit about it, you will end up with numbers that look a lot more like this than they otherwise would. I already said that something like 60% of matriculants to medical school come from the upper quintile economically. Well, that's not who we're getting, but you have to be explicit about that in your selection process. There is no way we would get 70% of our students from inland Southern California. We do not produce anything proportionally like 70% of our applicants from that region. So we would not get anything like that if that were not a specific and explicit filter that we put in place to look for those students.
Can I ask a follow-up? So that, those are the admissions criteria, the selection. Are you proactive in actually going out and looking for those students and actually getting universities like ours to, encouraging the students to apply?
So some, but not as much as we should. There's a lot of work still to be done. So I mean, you can go back to this and you can say, this still doesn't actually look like the community I described to you on those first few slides. There is still work to be done. A lot of work to be done. So for instance, our natural partner, Cal State partner, would be CSU San Bernardino, right? Like it's 5 inches away from us. And we actually don't get very many students from them, and we have not worked out the mechanism by which we can effectively partner with them. to help encourage their students to be a part of our program. Not because we haven't thought about it, but because we haven't figured it out yet. So not as much as we should. That is an enterprise that remains sort of an opportunity not yet fully explored. But your point is well taken, which is this doesn't happen by accident. It is a deliberate, intentional activity on the part of schools to choose to bend the curve on what the workforce preparation looks like.
And it costs resources.
And it costs resources, it does, it does. But there are 52,000 applicants, right? So it's not like I'm lacking for people to sift through. I just need to sift with a different set of filters.
Can you say something about the financial incentives that you give to some of your students to stay?
You guys should give this talk because you're bringing up all kinds of things I forgot to include. Well done. So in addition to sort of structuring our experience so that we recruit from the region, meaning they're more likely to stay here, and we built a residency program so they'll end their training here, we also recognized that we could add an economic incentives to stay here. Now, I'm not an economics sort of person, but my understanding is money matters to people. So we have, not universal, but have put in place a loan to scholarship program where you come in, we identify you as sort of a match for what we would like to see in our practice or in our practicing in our community in the future. And we say to you, we'll offer you the following deal: 4 years in medical school and we'll pay for it. If you agree to come back and practice for 5 years in Riverside, San Bernardino, or Imperial County, in one of the 6 high-need identified areas: family medicine, pediatrics, general internal medicine, psychiatry, general obstetrics, gynecology, and general surgery. If any one of those 6 general specialties are of interest to you, and you are willing to do 5 years of service, then what started out as a loan gets converted to a scholarship and you don't pay it back. If you decide for whatever reason that actually, doing boobs and butts in Beverly Hills is what you actually sort of were born to do, then, God bless you. We will graduate you too. You'll pay back that money, thank you very much, and we'll put it back into the pot for the next generation of student thinking about what they might be doing. So we've built, in addition to setting up the population of our students to be more likely to stay in the region, we've also made it economically easier for them to do so and to select the specialty practice areas which match best with our highest need in our region. As I said, we need everybody, but we don't have equal need across all disciplines, and those 6 domains are the areas with the highest demonstrated need in our region.
Well, I'll intervene. So it was a curious moment early this week when Dr. Adams and I asked the students in our healthcare seminar whether any of them were considering going into medicine, students who are interested in medicine as a subject, and all of them said no. And a couple of the students said something along the lines of, well, I'm not that engaged by science. And it seems to me a sort of underlying theme of your presentation today is that the skill set that has traditionally drawn people into medical school or that has been rewarded and cultivated in medical school maybe is not the skill set that you and UCR Medical School thinks is the most important skill set to cultivate in would-be aspiring physicians. So
yes.
I'd be curious to know, what would you say to a student who expresses that sort of sentiment, perhaps to suggest to them, hey, wait a second, maybe you have a skill set that's more suited to medicine than you might recognize.
So, let me say right from the start, if you're a philosophy major, you have no future in medicine. It's impossible. I say that because I was a philosophy major, just for those of you who are, I'm not insulting you. I am your people. I actually think not only is what you just said true, that there's a skill set amongst non-science people that is important. I actually think the skill set is non-science. So that's a whole additional talk and or seminar, but the reason that I built the Center for Humanities in Medical Practice is exactly because I believe fundamentally the practice of medicine is a social science, humanities-based discipline. You need to know science because that's how it works, but it's not how it's done. That's how it works, but it's not how it's done. How it's done is with communication and critical thinking and pattern recognition and logic and ethical behavior. And if you look at the competencies that even among non-forward thinking medical education institutions, we say we are trying to impart to our learners, there are 6, only one of which is medical knowledge. The other 5 have nothing to do with science. It is things like interpersonal and communication skills, and professional and ethical behavior, and systems-based practice, which is our sort of systems science, if you will, which, my apologies if any of you are in systems science, but let's face it, it's not science. It's systems thinking, which is important and which I am actually quite engaged by, but it's not science. The social sciences are what actually make effective healthcare systems and effective individual healthcare practitioners highly effective operators. It is not the underlying science. So not only would I say to people who are not science engaged that you potentially have what you need, I would say actually that's where I would choose to draw the future physician workforce.
Student fellows, this is, I mean, you'll have an opportunity later today. Was it? Jacob?
So, can you speak a little bit more about ethics training when it comes to medical school? Is there like an accreditation body or curriculum that you have to abide by in order to have these ethics classes, or can you just choose to insert them as you want?
Let me see if I understand. Are you asking whether or not there are pieces of the educational curriculum that are sort of ethically oriented and required by accreditation standards that I have to do that? Or are you saying, are there generally recognized ethical systems within which physicians are expected to practice?
So, based upon my research, there are some ethical classes that physicians do have to take. But if you want to extend those classes and to include more ethical classes,
yes.
How does like the system of accreditation go?
So the accreditation is silent on the issue. So as long as we meet the basic pieces that we need to keep the doors of the medical school open, then you have a fairly wide range of opportunities that you can make available to your students. And ethics is certainly a piece that I believe should be bolstered in medical education because, frankly, every single day is fraught with the opportunity for sort of ethical missteps. Every decision that you make every single moment of every single day as a practicing physician is an opportunity to get it wrong. And I mean ethically wrong, not like wrong science wrong, but just like, oop, that was a not particularly well thought out ethical decision I just made. It's a thought that should be crossing through all of our brains on a moment by moment basis. Historically, and even now, the first thing that you will hear when you say we need more X in the curriculum is that we don't have time for anymore, so tell me which part of Y you're going to take out. And in part, I think that's a legitimate conversation to have, and I'm willing to engage in that. But the other piece, I think, is that that's just like the idea that accreditation limited what we could do. I think the idea that we are time limited is actually overblown. Because if you take seriously the idea that I'm proposing is that every moment of actually engaging in medical practice is an ethically sort of framed experience, then we're doing it right now. We're just not critically framing it in a way that we're being reflective about it. So it's not that we're not developing ethical habits. We are developing ethical habits, and we're developing the worst kind of habits, which are unexamined habits. Done because that's the way I've always seen it done, or done because nobody ever sort of reflected back to me that there might be an alternative. Or, think of the ways that we develop bad habits. But every single moment of every single day, every single practicing physician is in fact engaged in developing ethical pathways, which will become ethical sort of shortcuts for them. We do it clinically, we do it ethically, we do it in systems. We develop these kind of well-worn pathways. Where I grew up, there are 1 million cows around. You give them the whole field, and they will walk down exactly the same path from one pasture to the next, all day, every day, never going anyplace else. Where they walk is where they walk. And it's a matter of sort of developed pattern. Physicians are much like cows in that regard. We will practice in the same sort of way. So what I would say in terms of reflecting back on what we should be doing in the curriculum is we don't necessarily need to build something new into it. We just need to build a reflective component to this so that we are thoughtful in how we are developing our pathways through the ethical pasture, if you will.
Others? Well, okay then. Let us thank Paul again. This was a fantastically informative talk, and perhaps it will lead to some initiatives here on our campus to get some students to think about becoming medical students and sticking around our region. So let's thank Paul again.